Can everybody hear me?
Yes, we can hear you.
Excellent. So this is a lecture that's necessitated by the place that you work. And although pulmonary arterial hypertension is a rare disease, there's about one or two or three places in every state that has a large pulmonary vascular center, and we're one of them. By definition, then, we will have a fair bit of patients, and on the inpatient service, it'll seem like lung transplant and pulmonary vascular disease is more common than asthma. Nonetheless, that's not the case. It's a disease of about 1 in 500,000, between 1 in 500, 1 in 300,000. But on a practical basis, then these patients are coming in and out of the house. They will have special medications that no one's ever heard of before or used. And our role as the division directing this is then to ensure that medications that are on a restricted list get entered in a timely fashion. It is in general, because the MICU fellow is on call 24/7. When these pulmonary vascular patients get admitted to the house, the MICU fellow will be called to place orders. And so we're going to just review that process, real practical learning stuff, so that when you are in the MICU, then you'll be able to access the kinds of things that are there. So a couple things are key to be able to do this. Number one, having EMR access, obviously very important. And so Layla, as far as you know, everybody's got EMR access. Is that true?
Yes.
All right, very good. So I am going to share my desktop here, and hopefully this will come out. Slideshow up for everybody?
Yes.
Yes, okay. Very good. So our goal today is to understand the different medications, identify key elements in the dose, calculations, and ordering. Be familiar with S-Drive. So Layla, as far as you know, how is the permissions to the S-Drive going?
So Pauline is working on that for the.
All right. Yeah, that always seems to be a difficulty, even though we know it's coming. And then troubleshooting, and then just a bit of ensuring that we get this right, because there are some problems that can pop up when this doesn't work out well. So in any case, worth doing. And let's then start from here. The pulmonary arterial hypertension classification system, or my flavor chart, so to speak, divides the universe of high blood pressure in the lung into at least 5 different categories. We're primarily concerned with this purple flavor, but the important thing to remember about high blood pressure in the lung is that it's an observation and not a diagnosis. And what causes the high blood pressure dictates, number one, its prognosis, and number two, how to fix this. And with few exceptions, the treatment of each of the colored boxes is unique to that box, and you don't cross over. So what's good for the purple flavor is no good for the cherry, et cetera, et cetera. So just a prelude to things that are going to come regarding future lectures. The pathophysiology is part of the unique aspects of this, and it is a small vessel, 100 to 400 micron, occlusive proliferative vasculopathy. This is an pulmonary endothelial-based disease process with profound molecular perturbations, which ultimately lead into dysmorphic, occluded, and hypertrophic vessels, which cause right heart failure and ultimate death. Hemodynamic progression is insidious. Because we're just a little late this morning, this is going to be a prelude to future lectures. But suffice it to say that as pulmonary pressures rise, cardiac output ultimately will fall, and the patient's ability to increment cardiac output with exercise also decreases, leading to their dyspnea. What kinds of pressures are we talking about? This is a slice from the National Registry of 168 patients at 32 centers, which was formed in the 70s and 80s. And now, almost 30 years ago, patients walked into clinic with a mean pulmonary pressure of 50, a right atrial pressure of about 8 to 10, and a cardiac index of about 2. Once again, 30 years later, people walk in with a mean of about 50, a right atrial pressure of about 10, and a cardiac index of about 2. So as rare as this disease is, patients look monotonously similar, and this can actually aid in a number of our diagnoses across the board. It's a dismal disease, having a survival curve worse than 3A lung cancer. And the sicker you are, the quicker you die, with untreated New York Heart Class 4 median survivals of 6 months or less. Even treatment does not get rid of this, and so this is a 7-year, 40% mortality, even among patients with normal functional class. So let's review the therapies to some degree. They're targeted in 3 different molecular approaches, either repleting prostacyclins, blocking a bad guy called endothelin, or augmenting the signal of nitric oxide, which is often deficient in vessels, by 2 different mechanisms, either decreasing the breakdown of middle message cyclic GMP, or augmenting its production through a cyclic GMP stimulator. We also have oxygen, diuretics, and other things, but these haven't fundamentally changed the survival of pulmonary arterial hypertension. So if we look at prostacyclins, there are both inhaled versions, oral versions, and parenteral versions. And so these are all contained in the order sheet. Currently, we use both Voletri, flavor of epoprostenol, or treprostinil, which is Remodulin. It's important to understand, as I'll review these, that although Voletri is exclusively IV, Remodulin can be given under the skin through a subcutaneous pump, intravenously, orally, or by an inhaled route. These routes and efficacies are not equivalent. You can see that the molecular appearance of these are similar, with the exception of, I'm trying to get this out of the way, sorry about that, so that this doesn't, this isn't blocking our screen. Okay. And so the other way, you can see that all of these molecules are very similar, with prostacyclin rings here as the active center, this being replaced by an aliphatic ring, with the exception of this last molecule called selexipag. Selexipag modifies the prostacyclin pathway, but it's a non-prostacyclin oral agent, which binds to and stimulates the IP3 receptor, leading to intracellular increases in cyclic AMP and ultimately calcium mobilization. If we look at the different delivery systems, then we have, let me just go back, both Voletri as epoprostenol and treprostinil can be delivered IV, and you'll see a fair bit of these. Both of these are expensive. Both of these are thermostable, not requiring ice. The primary difference between treprostinil and epoprostenol is their longer infusion half-lives. Treprostinil half-life of approximately 4 hours, epoprostenol half-life of approximately 1 to 7 minutes. And so this is relevant in planning. I'll take my first liberty of detours at this point, and then realizing that both of these are delivered through a CAD pump. There's a pump part and a cassette part. The cassette part holds 100 milliliters. Both nurses and patients will be able to tell you how much liquid is left. And it's important to know that although we replace these every 2 days for treprostinil and every 24 hours for epoprostenol, the medicine doesn't disintegrate magically at those 24 and 48-hour time points. And so on a practical basis, if you need a little bit of time, one of the issues might be how much medicine is left in the cassette. Even though it's 24 hours, if there's 10 or 20 cc's left in the cassette, the typical infusion rates will be somewhere around 1 to 3 milliliters an hour. So you can mentally calculate how much time you have left. We really don't like to run the pumps much beyond about 8 hours because they start alarming typically and may then kind of run dry a little bit, even though on the dial there may be 6 or 5 or 7 milliliters left in the cassette. But if you've got someone with a 30 milliliter residual reservoir volume left, you certainly have a few hours to be able to get in the orders, and they can continue to use that drip, even though it's a little bit over 24 or 48 hours with no difficulties. So that's sort of a pearl to remember, that you've got a little extra time and just see how much medicine is left, and that'll buy you a little bit of time to both get the right dose, put it in, and be able to clear the way for infusion. The other thing to review on this is that although these are administered by continuous IV infusion, that IV can be anywhere for the IV delivery. So this can be infused peripherally, and some people lose track of that. We don't send people home with peripherals in general, but we do for PICCs occasionally. And certainly when a patient is going out of the ICU, as long as they have a couple peripherals, it's perfectly fine to send folks to Tower 5 with infusion through a peripheral IV. So also recall, people come in with malfunctions of Hickman's from time to time, and the answer is start a peripheral and hook it up to that, and then that gives you all the time in the world to fix the Hickman or any difficulties that may arise from that. So again, another second pearl here, IV infusion can be peripheral. Start the peripheral, get it infused in through that, and then that'll give you lots of time to do other things. Because of the longer half-life, then mistakes can be magnified. If you dramatically overdose treprostinil, you will live with those mistakes and potential serious complications for about 4 hours. And so whereas EPO, the problem may be severe, but it'll be over in about 5 to 10 minutes. I told you that subcutaneous delivery was also possible with treprostinil, and this is the modified insulin pump that many of you have seen on diabetics. It's through a subcutaneous hub with a small stem on, and this is planted with a small injection type device that has then implants and then withdraws the inserting needle through the center of the hub. Not anything you have to know about, not anything that you would have to order. These are all available from our pharmacy, and just simply putting in the medication order will then access the ability to replace any tubing, replace any hubs, or use any injection material that needs to be used. There is an inhaled version, as I told you, of treprostinil. It's called Tyvaso. The one issue with this is that patients are dosed on breaths, and those breaths are actually very carefully monitored by this relatively sophisticated nebulizer computer. Patients will be on typically 3 to 9 breaths, although we're using 12, 15, and even 18 breaths 4 times a day. The key to this is, although we have the medicine in our pharmacy, these pumps are assigned to each patient, and they can't easily be cleaned and reprocessed, so we do not stock any of the inhalers for treprostinil here. Interestingly, there's probably a dry powder version coming in the next 2 years, but for right now, if someone's on Tyvaso, they have to bring their inhaler from home. They should know better, but you and I both know that patients can occasionally forget these and so forth. If you run into this where someone's on Tyvaso but has forgotten this, there are options and ways we can deliver it through regular nebulizers that we use for asthma meds. It's probably best just to call me at that point. Although there's an ordering process, it's a little bit odd, and often you'll need me to walk pharmacy through it. But again, key for Tyvaso, patient has to have his or her nebulizer. If they don't have it, family members need to bring it. If that isn't going to happen in a timely fashion, just call me and I'll walk through alternate ways which are less satisfying, but able to deliver this through a more conventional nebulizer. Oral treprostinil, usually three times dosing, rarely twice daily, but it can happen. It's typically with food. And as you can see here, there's a number of dosing regimens. So a typical dose of oral treprostinil might be 2, 3, 4 milligrams or some fraction thereof 3 times a day. We have the highest dosed patient in the world here, who's actually taking 22 milligrams twice daily, and he's actually in-house right now. I think he's on 20 or 21 or 22 twice daily. And so in any case, with the exception of that single patient, most doses will be single digit 3 times a day. We stock all the different pill strengths, so if someone's on 6.75 3 times a day, we can make that, the pharmacy should be able to make that up by various combinations of these 0.125, 0.251, 2.5, and 5 milligram pills. Once again, all of these medicines, whether they be oral, inhaled, subcutaneously delivered, or intravenously delivered, are restricted drugs. Restricted drugs means that the pharmacy has to follow special rules to get those, to dispense those. And the list of providers is very, 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 very short. And that list of providers is limited to pulmonary fellows, pulmonary attendings, and then for sildenafil, a handful of heart failure attendings and PAs. With that exception, no one else will ever be able to order these. And in point of fact, when they even search them in the EMR, those searches will not come up for a non-authorized person. So important to know. And in the short run, any questions so far on on some of the basic information that we've given and some of the insights of the current fellows that might be able to enhance some of the learning currently. So the first question, any questions? We're going to go over practical aspects, how the EMR works and so forth in a bit. But any questions about the basic prostacyclins and the different flavors of those? Layla?
I don't think so.
Very good. So then we have also endothelin antagonists. There's 3 flavors of endothelin antagonists. They all end with tan, bosentan, ambrisentan, and macitentan. I think we might have only 1 patient left on bosentan. Pretty much everyone else will be on ambrisentan, which has 2 strengths. So you have to know that. Macitentan or Opsimet only comes in a single strength. Again, these are oral. Interestingly, it comes up from time to time. Ambrisentan can be crushed and put down NG tubes. The crushing just can't be done with pregnant females, since the powder is fetal toxic and it can be absorbed either by the inhaled or subcutaneous route. So Letairis, ambrisentan, Opsimet, macitentan. And then there are various flavors of generics floating around right now, and at least one of them isn't always obvious that it's ambrisentan. So if someone's giving you some weird generic names, try to push for the generic, either ambrisentan, and then tadalafil has one weird generic name out there too. As I said before, most of this will come in later kinds of lectures, but nonetheless, they're teratogenic. They can cause some anemia and peripheral edema. The macitentan can't be crushed down, ambrisentan can. Phosphodiesterase inhibitors then, certainly tadalafil, sildenafil are things we have. Some of the advantages of sildenafil is that can either be given through an oral suspension, tablets, or by injection. And obviously the caution with sildenafil is that it shouldn't be used with nitrates, and it should be used only in caution with alpha blockers. These are both available in all flavors. Lastly, also modulating the nitric oxide pathway is riosequat or Adempas. This is a soluble guanylate cyclase stimulator. 3 times daily, can't be given with nitrates and PDE5s, and again is available on the pharmacy. They are on the restricted high risk list, as I told you about. Our fellows, pulmonary staff, and a few heart failure staff and PAs can order this. And once a PH patient is admitted, typically the MICU fellow, rarely the consult fellow, will be called and be expected to place orders. So let's go over that. Number 1, identify the medications, doses, and routes that are currently given. Most patients will be on more than one medication. If someone's calling with just one medication, you may want, it's worth a second ask. Are you sure they're not on something else? The second step then will be to confirm these medications with S-Drive sheets. We'll go over that. And then lastly, we'll place the orders under the pulmonary hypertension search in the EMR, which brings up a special ordering sheet, which will only come up to approved providers with this search. So residents can't search this for you. They won't get a result because they're not on the approved list. So here's the S-Drive pathway. I'd like to just review this a little bit for everybody. So it's when you go into your computer, it's under the computer icon that's in the that will come up and is there. You will then have an S-Drive, so the shared data server S-Drive, and then the subcategories of that are pulmonary folder. Then within the pulmonary folder, there's a pulmonary and critical medicine folder. There's a pulmonary vascular team folder, patient charts, active patient electronic charts. And this is a little bit what that looks like. And so it's worthwhile to practice this once you get out. Find the S-Drive, make sure you have access to it. Layla just told me that there's a little bit of seems to be a little bit of difficulty with that, although it should have been awarded to you once you had access to the pulmonary and critical care S-Drives folders and the fellowship folders. So we'll have to run that down again. These sheets look a little bit like this. Here's an example. There are multiple tabs on the bottom, including demographics, past medical history, current list of active medications, and this is worthwhile to double check what else they may be taking. And then lastly, when people are on infusion therapy, they will have tabs which will be hopefully relatively current regarding their doses. As you can see on the top of the list, there are issues of what the concentration is, what their current dose rate on the, what their current rate on the pump is, what their current nanograms per kilogram per minute are, the concentration of the medicine, and what the pump runs at, how many mils per 24 hours. Troubleshooting on this then, coming from the floor, again, most of the nurses on Tower 5. The other thing that I need to point out is that these patients on infusion therapy can only be admitted to Tower 5 or an intensive care unit. So again, CCU, MICU, heart failure unit, even some of the trauma units and surgical units are okay admitting an infusion patient to, or Tower 5. If you get a call for an infusion patient and they're in Lakeside or something else, the first answer is transfer them to Tower 5. So that's because that is an issue. So the second issue then will be to cross-check on the numbers that may be available to you. So again, the key pieces of information to get from the nurses that may be admitting the patients are, what is the rate on the patient's pump? And how do they mix? Again, a quick, and that is easy because when there's discordances, they can all be settled as, in general, unless, I'm trying to think back if a patient has ever really messed up their infusion rate. It's not clear to me that I can remember a single instance of that where a patient dramatically messed up their infusion rate. So in general, when patients come in the hospital, their infusion rates will never be touched when they come through the door. When you order that, you're never going to change the pump rate. And we just need to then ensure that the concentrations and the amount of medicine that gets added to the cassette to be mixed up is correct. And then these correspond to the inevitable consequence of having a concentration of medicine run at a certain rate. So again, Pearl here, in general, pump rates, and almost without exception, will never be altered in patients coming through the door. And so just ordering to ensure that that rate, their current concentration, continues to be provided is what is going to be important. Here's the search tab under orders. So you go to put in orders, you look and you type in pulmonary hypertension. That gives you this sheet. So this sheet is organized into both infusion therapies on an upper tab and oral therapies on a lower tab. The infusion therapies then will have pre-mixed 5 or 10 nanogram 5 or 10,000 nanograms per mil concentration. That is alternately 0.5 and 1 milligram of med per 100 mil cassette, and also a free form where you can enter the patient concentration and mixing orders in the likelihood that they wouldn't be on 5 or 10, which are typically the starting doses of this. Once again, infusion and then oral meds underneath. Again, the extended oral meds, which also contain the inhaled medications, treprostinil by inhalation and so forth. So the meds will just be the single, oral doses. Most of them are pre-populated with doses when they are fixed. So for example, macitentan, ambrisentan will be populated with typical doses of 5 or 10 milligrams and either once once daily intervals. The sildenafil will be typically populated at a 25 milligram 3-time daily regimen, or a 20 milligram 3-time daily regimen, as will tadalafil at its 40 milligram once daily regimen. Very, very, very rarely alterations to this may need to be done. Those can always be done in consultation with me, but those are typically what will happen about 98% of the time. On here is also the inhalation route for treprostinil. So Remodulin inhaled is called Tyvaso. Remember that they have to have their own computerized handheld nebulizer. If they don't, then give me a call and we'll figure out what to do. One part of this then is an interesting area that to implement these, there are some medications, Riosequat, macitentan, and ambrisentan, which are medicines that have potential teratogenicity, and therefore one has to confirm, which we do, that the patient has been educated on these side effects and so forth. We have all that paperwork on file, and what this will answer is a checkbox which says, if you order macitentan, is this being ordered by a confirming hospital which has enrolled the patient? The hospital is considered the provider in this case. And so the verbiage comes up is that, has this been, you know, is this ordering entity a confirmed enroller? And the checkbox to that is yes. And by checking it, you are not checking that you yourself educated the patient, filled out the paperwork or everything else, but indeed that the hospital is an approved provider and enroller, and that they have the paperwork on file. No patient can be on a medicine without the paperwork on file. So these medicines cannot be even shipped to a patient without the paperwork being on file. And we do not start it in-house if in a rare circumstance. And I'm trying to think if I have really ever started any of these endothelin antagonists in-house. It's exceedingly rare, but when we do, we approve the paperwork. So when the dialog box comes up and says, is this being prescribed by an approved enroller? The answer is yes, but you're answering yes to the question, essentially confirming that the hospital is a preferred enroller or a confirmed enroller. And again, these are just pre-populated typically as the medication, the dose, the route, and the frequency. So it's really just usually a checkbox at the beginning of this. Again, all of this will come up automatically when you search pulmonary hypertension in the dialog box of the ordering sheet. So let's just go over a few practical issues with pulmonary hypertension medications, patients and their medications. You really don't have to troubleshoot this, because when there's substantial issues of troubleshooting, really just get me on the phone or whoever's calling pulmonary vascular at the time. I know we're at 8 o'clock and I really want to wrap this up, so maybe I'll leave this to our future lectures. The one practical issue, or the two practical issues that I want to go over is number one, I told you that infusions can be given peripherally as well as centrally. Absolutely true. The one caveat is that they must have a dedicated line. Nothing else can go through that line. However, if they have a dedicated port in a triple lumen or a dialysis catheter, for example, that's fine. Let me repeat that. All infusions require a dedicated line because of the pH. What happens if you have a non-compatible solution? If you Y in, for example, potassium with this, it'll crystallize because of this pH. Many medications will crystallize and clog the tubing. So again, although you can infuse peripherally or by central line or by triple lumen or by side port of a swan, that has to be the only thing going through that port. You can get away with saline or water, but really just don't put anything else through it. So that's one thing. You can. Number two is that really just making sure that the dose is typical. Usually we are in the range of 10 to 100 nanograms per kilogram per minute, but we do have a few rare patients out there. If we're going to increase dose, they're generally in 1 to 2 nanogram per kilogram per minute in changes. We essentially try not to infuse or interrupt for any reason. A typical question that comes up is that, oh, your patient is on infusion therapy, they're hypotensive, I read that this can be a vasodilator, I want to stop this. The answer to that is no, you don't. The issue is because it is facilitating forward flow. If someone's hypotensive, it isn't because of the infusion rate. Something else bad is going on. And stopping it will only make that bad worse. In general, you will read on infusion therapy that abrupt cessation of infusion therapy can be life-threatening. In point of fact, I've only had one person killed by stopping an infusion, and that was precisely under the circumstances that I just told you never to stop it in. One of our patients with horrible liver disease showed up septic in a small peripheral hospital in the middle of nowhere. The patient was quite sick and quite dependent on infusion therapy with really big RV, and they were septic. and the physicians decided that, oh, well, this is a vasodilator, they're septic, I should stop this because it's probably helping make them hypotensive. Within about 45 seconds after stopping the infusion, which was epoprostenol, the patient coded and died. So again, epoprostenol was the only thing maintaining forward flow and facilitating forward flow in this patient. You can start pressor, you can do other things, but don't stop the infusion. This is sustaining whatever forward flow that they have. Pump malfunctions are uncommon, and the nurses are very good at doing these. Inadvertent drug overdose is rare. The last one we saw here in the hospital was over 12 years ago. And if that's, and is characterized by flushing, you can get hypotension there, but all this usually happens within a minute after someone starts a new infusion. So if someone has profound side effects, flushing, tachycardia, nausea, emesis, within minutes after starting an infusion, suspect inadvertent drug overdose and get me on the line immediately. That might be the only time ever that one would consider stopping an infusion. Like I said, I haven't had to do that for 12 years. So it's incredibly rare. Usually there are always backup pumps. So when patients come in, they have 2 pumps. When we start in-house, they have 2 pumps. If there's a problem with a pump, switch the pump. These are some of the simple kinds of things, but I think that what's important then, as you become rotating through the medical ICU and or rarely the consult service, you will be asked to put in these medications. It's important to cross-check the doses and kinds of things on the S drive. If you're at all in any confusion about this, get one of your senior fellows around. They'll probably be on call somewhere. And if you can't get a hold of them and you have questions, please just call me and we can work through the issues of ordering these. Again, I think that you'll find that these are a very interesting group of patients, both physiologically and molecularly. You are at one of the handful or a couple handfuls of places in the country where this is done on a regular basis. And at any one time, we typically have somewhere between 1 and 5 patients in-house with this disease process. And so the likelihood that you'll get called at some point is very high. With this, I'm going to close, but what I'd also like to do is invite the current fellows, senior fellows on to give some of their stories and pearls and advice to entering fellows on ordering. So I thought I saw Brent and Layla on there at the very least. Can some of you kick into some of your thoughts and challenges that you've had, ordering on call and so forth for these patients?
Yeah, sure. So I'll go ahead. So like Dr. Schilz says, the biggest thing is to confirm the meds with the patient, and the patients who are on infusion therapy are obviously very reliable. So always check with them. They know what they're on. So even if the resident calls you, you don't know what the patient is on. They're on 1 med, but really they're on 3. That's why it's important to double check on the S drive and then also check with the patient.
Right.
Yeah, I actually wanted to give the pearl that, it's all, really want to echo that you can always run it peripherally. I mean, you get into so many trouble, so many times, like problems with the Hickman or something like that. And yeah, you always can run it peripherally, and you have to know how to prime the, how to prime the IV. You have to prime the IV first, but the amount of liquid you need to prime the IV is always on the packaging of the IVs, and there's a certain number of clicks that corresponds to a certain number of mLs to help prime any given IV. So if you have an inexperienced person doing it for some reason, that's also another small pearl.
Boy, that's a great one, Brent. The nice thing to do is if you are caught in the middle of anything, for the most part, and people are on treprostinil, if you're really, really, really stuck with the weird issues of priming and you're on treprostinil, the average amount of liquid in a Hickman is usually somewhere around 1 ml to 1.8 mils-ish. If you have something infusing at 1 mil per hour or 2 mils per hour, if you just turn it on, it'll take about an hour to work through the tubing. And if, as Brent said, this can always be negotiated, but if you're in a terrible no-win situation in someone who's obviously destined to do something horrible, and the patient is on treprostinil, even though it's not perfect, because of the half-life of treprostinil, you could get away with just hooking it up, turning it on, and then just letting it prime itself as it runs through over the next, you know, and you'll get medicine from the hub to the tip, you know, within somewhere between 30 to 45 minutes, even if you just do that. You rarely have to do that, but that's a fallback as well. But Brett, that's a great tip. And the priming is something that all the nurses that are skilled in doing this understand and will do for that. It's important not to either, if for whatever reason, it's important not to flush medicine through this. The lines, as I said before, are about 1.8, somewhere between a mil and 1.8, maybe up to about 2 mils. And that represents an entire hour's worth of medication. And so it would be a little bit like giving a push of norepi or something, you know, and giving, you know, an hour's worth of medicine in 5 seconds. You know, the wisdom of that or the lack thereof is self-apparent. And so these lines are big enough that you don't really want to flush saline through it. If you ever have to flush a line, you can withdraw medication out until you get blood, discard that medication and blood, and then you can feel free to flush with saline once you've confirmed that there's no medicine stuck in the line. Again, what you want to get around is bolusing that column of medicine into the patient over a tiny amount of time. But great perspective, Brent. If you're running into trouble, use, you know, call your senior fellows. As you can hear, they're very skilled at doing this at a very high level through the years out of necessity. And I'm always available, or someone is on call for pulmonary vascular disease that can help walk through this as well. So thanks for your attention. Sorry about the little hiccups getting started, but certainly confirm after this. I would invite you to pull up a patient, make sure you can get into an S drive, make sure you can find the folders and the sheets, and then when you're in the inpatient EMR at UH, then kind of poke around and make sure you're getting these sheets up, which confirm you as a provider to enter pulmonary hypertension medicines. If you are not receiving those, get in touch with either the chief fellows or our fellowship administrator to make sure that you have that access granted. All right, thanks everybody.